today. Unfortunately, I managed to pick up a bit of a cold from my kids, and so I apologize for my raspy voice. I don't have COVID, so that's good, but I still have the consequences of having to stay home so nobody else can catch this cold. So today I'm talking about the utility and nuances of TKV measurement, and I will just forward my slide here. So initially we're going to talk about what kidneys look like on imaging, and what are the typical and atypical manifestations of polycystic kidney disease on imaging, and then some of the mimickers of polycystic kidney disease, and then total kidney volume, utility and measurements, and lastly I'll talk about ultrasound and total kidney volume. So CT scan uses X-rays to obtain images from the tissues, and X-rays are great in showing bones and air, but they're not very good in showing the soft tissues and differences in soft tissues, and so everything will kind of have this grayish tone, and that's why if you've ever had a CT scan, you'll know that often what we'll do is we'll inject you or the patient with a large volume of this high density contrast, and so you'll feel very hot and warm for about 30 seconds as the injection is going on fast. And we're doing that so that we can actually introduce some contrast in your body so that we can start seeing the differences in the soft tissues. And so you can see that when we inject the contrast and when you inject it quickly enough, then you'll get this high density of blood. This is just iodine that we've injected. It's high density of iodine that kind of flows with the blood, and as the blood first goes into the renal cortex, and here we can see the cortex beautifully enhancing, and eventually the contrast works its way. It gets filtered through the renal cortex into the medulla, and the medulla will start getting denser as the cortex becomes less dense. And if we kind of followed this through, then we would see that a lot of this contrast will end up into the renal pelvis, and that's how the normal kidney functions. MRI, compared to CT, has much better resolution in terms of showing the differences in the soft tissues. So we call that soft tissue contrast. So it has a lot better soft tissue contrast or contrast resolution. And how MR images the body is that it tries to image the protons, and it tries to image the protons by creating a very high magnetic field. And so that's why we have to kind of go in a tunnel when we're having MRs, because that tunnel has a very strong magnetic field that's actually stronger than the Earth's magnetic field, each one of these magnets. So we go inside that magnet, and then radio waves are sent in and radio waves are received, and we try to excite the atoms. And what we're really doing is we're imaging the protons, and depending on where these protons are, we kind of will image them differently. And so you'll have these terminology on MRs when we're talking about T1 weighted and T2 weighted images. Basically, what we're doing is we're kind of tipping the way we're imaging to show the different types of hydrogen atoms or protons. And so those hydrogen atoms, they may be in proteinaceous or in soft tissues, or they can be in water. And so we kind of T1 weighted images kind of shows it more when it's not in a watery environment, when it's in protein and fatty tissues, and T2 weighted images shows the protons or the hydrogen atoms that are in water. So we kind of show that we can show some of those tissues very nicely just by looking at what kind of proton, what kind of hydrogen atom, or where that hydrogen atom is placed. But nevertheless, we want to see the flow of blood, and so to best see that, we also inject intravenous contrast in MR. MR is really exquisitely sensitive to that contrast, and so we don't need large volume. You'll just get a small injection, And so here you can see on this T1 weighted image, we inject the contrast will look really bright. And as we inject, then, you know, the cortex fills in, and then we see the cortex fill in, and then we start getting filling of the renal medulla as well. So this is a contrast enhanced MR. So you've all had ultrasound, so you know that ultrasound uses sound waves, and ultrasound is wonderful imaging modality because it's really well tolerated, is basically completely safe with no side effects, is highly available and very cheap. But it's not very good for patients who have high body mass index, for larger patients, because those sound waves can have trouble going in very deeply. And also, it's very kind of it is somewhat operator, not very, but somewhat operator dependent. And so the reproducibility of it is not as good as, let's say, with CT or MR. So we just showed CT and MR, and CT doesn't have a lot of good tissue contrast, and so we need to inject with intravenous dye. But that iodinated dye that we inject can have some issues, or can potentially affect the kidneys and affect their kidney function. And so that's one of the downsides with CT. So we don't want, you know, patients who've had potential problems with kidney function, we may want not to inject the dye. The other issue is that it uses X-rays, which is not good. There is a very, very low risk of developing tumors and cancers from having high doses of X-rays, and so high doses of radiation from the X-rays. And so, MR seems to have the best of both worlds in terms of both its ability to demonstrate the different types of tissues, and also the contrast for MR is not nearly as toxic as the one with CT, although the CT is also pretty darn safe, but very rarely, occasionally something happens with the CT contrast, much less common with MR. The problem with MR is that they have to be inside that big magnet, and that is not easily tolerable, especially if people have some issues in terms of being in tight spaces. Claustrophobia can be an issue. And so the tolerance of MR is less than with CT or ultrasound, patient tolerance. As well, it's not as available, and it's more costly. So those are the downsides of MR. So let's move on to what polycystic kidney disease looks like on imaging. So the appearances of it to some degree depend on, how old is the patient and what kind of mutation they have. If they have a mutation of the PKD1 gene that results in a protein that has little or no function, then the disease is relatively severe. And so even in younger patients, we end up seeing larger kidneys with lots and lots of cysts. And one of the features of polycystic kidney disease is that the cysts are distributed randomly, both in the cortex and in the medulla. And when the disease is in typical manifestation, it will be in both kidneys, randomly distributed all over the place. So this is a younger patient, 20 years old, and their kidneys are slightly enlarged for their size. And this patient is 30 years old, and the kidneys are really large, and really we don't see any renal tissue in between the cysts. So here you can see in between cysts, there's some renal tissue. In this patient, 42-year-old, in between the cysts, there's some renal tissue. In this patient, there is no parenchymal tissue left between the cysts. So even with, having the same type of mutation, the manifestations in the patient can be different. So this 42-year-old doesn't have as bad a disease as this 30-year-old. Now, with milder forms, so if the protein, the PKD1 gene produces a protein that functions somewhat, all the function is not gone, then the disease is there, but it is much milder. So in this 24-year-old, if you kind of really squint, you can see tiny little cysts. None of these are bigger than 5 millimeters. tiny little cysts kind of distributed in the cortex. And the kidneys are otherwise normal, and the function is going to be normal here. And in this 61-year-old, there are multiple large cysts, and the kidneys are really large, but we still see some normal looking kidney parenchyma in between, and so the kidney function may not be as bad. And here's a patient with a PKD2 mutation, which you've heard about today. And so in this case, the disease also tends to be milder. And so in older patients here, we can still see, really enlarged kidney with lots of cysts, but there's still some parenchyma that we see, whereas in PKD1 protein truncating mutation, the bad forms, we don't tend not to see any parenchyma at this age anymore. So those were kind of typical appearances, randomly distributed, bilateral, and symmetrical. It's important to identify the atypical patterns, and it's important to identify those atypical patterns because the patients will tend not to have as bad or as severe function loss in the future, especially as patients who have the typical patterns of bilateral random distribution of the cyst. So what are the atypical patterns? So one of the atypical patterns is that the disease only affects one kidney. So this is the unilateral form where you can see one kidney looks totally normal, the other kidney is enlarged with multiple cysts. But even despite this, in this patient, there's some parenchyma still left as well. So this is a 64-year-old patient, and they have a normal renal function, but unilateral involvement of their kidney. The disease can also be asymmetrical, meaning that both kidneys are involved, but one side has severe disease, and so about 70% of the total kidney volume is within one side. Hardly any parenchyma is seen in this patient. The other side will have a few cysts or could have multiple cysts, but just in one segment, with the remainder of the kidney being spared. So that was a symmetrical pattern of involvement. This can be, the disease can also be segmental where one portion of the one or both kidneys can have cystic disease, and then other portions of the kidneys are spared. And so something like this, where this patient has multiple cysts in the lower pole of the right kidney and a few cysts in the mid portion of the left kidney, but then there are regions in both kidneys that are uninvolved. There's also a lopsided pattern, and in this pattern, what we see is very, large cysts, and these large cysts lead to large measurements of the kidney volume, large kidney volumes. But in fact, there are just a few large cysts, and these few large cysts will have majority of the kidney volume, or majority of the volume of the total kidney. Majority of the total kidney volume. So the definition for lopsided is that there are 5 or fewer cysts, and when we calculate the volume of these cysts, that tends to be more than half the total kidney volume. And so this patient might look like they have really enlarged disease, really enlarged kidney volumes, but their renal function tends to be much better preserved. So not all cystic disease in the kidneys are polycystic kidney disease. And in fact, what I want to say to you as somebody who looks at people's kidneys every day, all over the past 20 years, I will tell you that development of kidney cysts is really a normal part of human aging. So, when we're born, very few of us, if any, will have cysts. And, by the time we reach the age of 50, very likely you will have cysts in your kidneys and or in your livers and or in your pancreas. So developing cysts in the kidneys themselves is not necessarily disease. But obviously, in some patients will have some other diseases that will have lots of cysts in the kidneys, and we'll go through some of these diseases. So there are patients who have genetic defects, and these genetic defects will lead to cystic disease in the kidneys. And then there are patients who don't have a known genetic defect, and they will have some other diseases in the kidneys that will mimic cysts or will have cysts. So this is an ultrasound of a 7-day-old baby. And in this 7-day-old baby, we can see that the kidney is actually enlarged. And on this ultrasound, cyst and water will look black on ultrasound. So there's all these kind of black areas in the kidney. And so there is cystic disease in this baby. But when we look more carefully at that kidney, and so here's me putting a very high resolution transducer or probe on the baby, and the baby didn't like it, was screaming and crying and breathing at the same time. So there's a lot of motion. So you can see ultrasound is exquisite and very good for motion. That's better than CT and MR that way. So here we can see that the cysts in the kidneys are elongated, okay, and they're centered within the renal medulla. So the renal cortex, that outer functional portion of the kidney where a lot of the filtration occurs, okay, that has hardly any cysts. The other thing is that when we see these cysts, these are not kind of round, but they're very tubular. And this disease causes the dilatation of the renal tubules. And so very severe in the medulla and can go into the renal cortex as well. So those are babies, but in adults, we can also see autosomal recessive polycystic kidneys. And in these patients, the renal disease tends not to be so severe. So they may not have renal failure, or they may develop renal failure at much older age than the babies that I showed you. So in this case, again, the same sort of thing where we see the cystic changes in the medulla, and the cortex doesn't have much of the cyst. And so when we look at the MR on this patient, for example, we can see that the renal cortex is spared and the cysts are predominantly within the renal medulla. They tend to also have disease outside the kidney when they have this milder form of autosomal recessive polycystic kidney disease. And so they get congenital hepatic fibrosis in the liver, and they also get malformations of the ductal plate in the liver. Then they can lead to things like Korosh's disease, like in this patient, with dilated ducts in the liver. Another genetic mimicker of polycystic kidney disease that can sometimes have a lot of cysts in the kidneys is von Hippel-Lindau. And so with von Hippel-Lindau, these patients are predisposed in developing renal masses and lots of cysts in their pancreas. But sometimes they also get cysts in the kidneys. And so on this T1 weighted MR with gadolinium with contrast injection, you can see that the kidney is quite enlarged and there are a bunch of cysts. And also these arrowheads point to renal masses, and these renal masses are renal cancers. And here's another patient, different patient, and we can see just a few renal cysts, but very severe manifestation in the pancreas. So the entire pancreas is kind of replaced with severe cysts. Tubular sclerosis complex often leads to replacement of much of the kidneys with these fat-containing angiomyolipomas. These are benign tumors in the kidneys. Sometimes, though, that the kidneys can have cysts. So like in this ultrasound here, the same patient on MR, we can see that there are randomly distributed cysts. And the differentiation here is the identification of these angiomyolipomas, which are relatively easily identified on CT, ultrasound, and MR. Sometimes the cystic disease is really prominent. And so like in this patient, the kidney on the left side is massively enlarged. It's pretty large on the right too, but not as bad as the left. And these asterisks are on cysts in the kidneys. also, these are the angiomyolipomas, and these we can easily identify because they have fat in them. So fat is easily seen on CT and MR, so we identify them as angiomyolipomas, and so tuberous sclerosis complex. So those are patients with genetic diseases. We also see cystic disease in patients without genetic disease, like I said. And one common scenario is patients who have have chronic renal failure. So for some reason, patients with chronic renal failure are predisposed to having more cysts. And so they also get these randomly distributed cysts throughout the kidneys, but the identification of these is easy compared to PKD because these kidneys are small, whereas in PKD, the kidneys get larger with the cystic disease. Like I mentioned to you, developing renal cysts is kind of normal manifestation of human aging. Like moles on our skins and sunspots and whatnot, we get cysts in our bodies, especially in the kidneys. And so sometimes those cysts become really very kind of prominent. And so in this patient, the kidneys are enlarged and have multiple cysts in them, but also the kidney function was normal in this patient, and there's no family history or mutation in this patient. And so we don't know why some patients have more cysts than others as they age, but I'm sure that next few years, next about 10 years or so, the research will kind of take us into why we in fact develop these cysts. Another disease that sometimes we get patients referred to that have this, and it's mistaken for PKD, is really severe dilatation of the renal collecting system. So this looks like what we call hydronephrosis. So the renal collecting system is really dilated, and it kind of mimics those cysts in the kidneys, especially on ultrasound and sometimes on MR. But if you look carefully, you can see that these cysts are all connected. And so this is the renal collecting system and dilated renal pelvis here and calyces. And so these patients will tend to have no symptoms or very occasional symptoms and normal renal function. And so you can show that these are collecting system by doing some kind of excretory test. And in this case, a nuclear medicine was done nuclear medicine study where we can actually measure kidney function and relative to the other side, and the kidney function is symmetrical, but and you can see there's filling of the collecting system with the radionuclide. Now, another disease that we get occasional referrals that mimics polycystic kidney disease is development of these parapelvic cysts. And so these are also commonly seen, and they sometimes they're very, very kind of prominent, where they kind of fill the entire central component of the kidney and will look really kind of dramatic. But despite their dramatic look, they basically have absolutely no clinical significance. Patients do quite well with these, and so it's an incidental finding, and we don't know why they're there. But anyways, we can separate this from PKD with the distribution, where their renal cortex and in this case the medulla are all spared, and this is all very central in the renal pelvis. That's why they're called parapelvic cysts. Okay, so why do we want to know the total kidney volume? Okay, we've found, studies have found that the total kidney volume is a biomarker of disease progression. I'm sure you've heard this already this morning. It's a biomarker of disease progression. So it doesn't, the total kidney volume doesn't tell us how bad the kidney function is today necessarily, but it will tell us, it will give us a good sense of how that kidney is going to function down the line, a number of years down the line. And so it will able to kind of help us separate patients who will have faster progression to renal failure from those who will have slower progression to renal failure or potentially even no renal failure at all. It's also used as endpoint for trials and cutoff for therapies to decide, patients who've had faster disease progression to receive the therapies. So how is total kidney volume measured? So the best way to measure it, the gold standard, if you like, is by manual segmentation. And that basically, I will show you how that's done. But there are other methods, including ellipsoid formula, and their automated and semi-automated segmentations. So just going back to the total kidney volume, it's not just the total kidney volume itself, but it's the total kidney volume that's adjusted for the patient's height and also for the patient's age. So height and age adjusted total kidney volume. And this excellent study from the Mayo Clinic basically showed that when we looked at the kidney volumes as compared to kidney function, there was not a great degree of correlation. But when we followed those patients down the line, we could see that in the future, patients who've had total kidney volume, high total kidney volume will have also lower kidney function. And those who had lower kidney volumes 8 years earlier will have higher kidney function. So it's a marker of future renal function. So how do we measure the total kidney volume? The gold standard, the manual segmentation, is also very time consuming, and I can tell you that after doing a few of these, you might start getting pain in your hands and wrists or shoulders because you have to kind of hold on to a mouse and go image by image or every other image and draw the outline of the kidney. And then you plug in the surface area and the multiple different slices of the kidneys, and you add the surface areas to get the total volume of the kidney. So this will require MR imaging often, but you can do it on CT imaging as well. And it's very accurate and it's very reproducible, but it's time consuming and also requires MR. MR is expensive, of course. So another way of approximating the total kidney volume is by using the ellipsoid formula. And so the ellipsoid formula is done as such. So you obtain sagittal and coronal images of the kidney and axial images of the kidney. So we image the kidney in 3 planes: sagittal, coronal, and axial. For the sagittal and coronal, we measure the maximal length of the kidney, and it's okay if you kind of oblique it. So this is a coronal oblique measurement, and this is a sagittal oblique measurement. This is the front, this is the back, and we kind of obliqued it a little bit towards the back here. So we obtain those 2 diameters, the sagittal and the coronal, and we get their average, okay? And we take their average and we multiply it by the transverse diameters. So the orthogonal plane in the axial plane, we kind of measure the 2 maximal 90-degree diameters. We take these measurements and we multiply it by the average of the sagittal and the coronal. And then we have to multiply that by pi over 6 to get the volume of an ellipse or an ellipsoid entity. And so we get the average multiplied by the transverse diameter and multiplied by pi over 6. And so we get the total kidney volume. In this case, 2.2 liters. So very large kidney. Us and others have done studies looking at how well does MR Ellipsoid, this rapid, relatively quick way of measuring total kidney volume, compares to the gold standard manual segmentation. And when we look at the measurements, we can see that the measurements most of the time will be well within 20% of each other. The standard deviation of about 2/3 of the measurements will be about 10% different when we use ellipsoid compared to manual segmentation. So it's not so bad. It's pretty good. And not only that, it's not so important to actually kind of get the exact right volume, as it's better to be able to get the correct risk class, the Mayo Clinic risk classes that are obtained. And so the one number means that this is patients for typical. We do these for patients with typical disease. That's why we wanted to separate those with atypical polycystic kidney. So class 1 disease, and so they're divided into 5 different classes from A to E, and D and E being more severe disease. And so MR ellipsoid, using ellipsoid formula, 86% of the time the correct class is identified, and 95% of the time ellipsoid formula is able to distinguish milder disease from the more severe disease. So 1A and B versus 1C to E. So there are also automated and semi-automated total kidney volume techniques, and Dr. Klein is going to be speaking later about these. And so I'm not going to spend time talking about those, because he has an entire talk on the semi and the automated techniques. We have also looked at ultrasound. So I mentioned why ultrasound might have an issue in terms of measuring total kidney volume. One of them is it's the variability in terms of measurements that the different performers or operators or the technologists will obtain. So depending on how you hold the probe and exactly what plane you're looking at, you might be able to get slightly different measurements. So there is that inter-observer variability that's higher with ultrasound. The other thing is that when the kidneys get really large, ultrasound will have kind of difficulty showing the entire kidney in one field. And so you have to use specialized techniques to kind of get the entire kidney, or show the entire kidney in one field. But overall, and this image kind of shows nicely, ultrasound tends to underestimate the total kidney volume. So the kidney volume tends to be larger than what ultrasound says it is. There are ways of measuring the total kidney volume on ultrasound. One of them is by just measuring the dimensions of the kidney, just like how it's done on MR. We kind of measure the maximal longitudinal dimension, and then we find the maximal axial dimensions, and we multiply it all together using ellipsoid formula. Another way is to do 3D reconstruction of the kidney, and that way we, just like manual segmentation, you draw out the outlines of the kidney, and that at multiple different slices, and the software reconstructs the full volume of the kidney, and so you can get this measurement as well. So this is using volume estimation by 3D ultrasound. So again, here you can see that beyond the image, we've had measurements beyond the image, and so we're kind of guesstimating exactly where that kidney ends using a 3D technique. And so we tend to also underestimate the kidney volume. So we performed a prospective study comparing ultrasound, these two different techniques, 3D ultrasound and ellipsoid method using ultrasound, compared to MR ellipsoid and the gold standard. And we found that with ultrasound, we tend to underestimate the kidney volumes a lot more than with MR. And that resulted in double the rate of misclassification with ultrasound compared to MR. We also found that there was not much difference between 3D ultrasound and ellipsoid formula. However, ultrasound may have a role, because in terms of separating who has high-risk disease, so that's MCIC classes 1C to E, versus those who have lower risk, ultrasound tended to have the same performance, pretty good performance, as ellipsoid method using MRI. So ultrasound underestimates the total kidney volume, and we didn't see any benefits from 3D ultrasound. the important thing is that because ultrasound underestimates total kidney volume, when ultrasound says a kidney is really big, it tends to be really big because it underestimates it. And so it may be a useful tool in identifying high-risk patients. So we're kind of looking now forward to seeing if we can use ultrasound in separating patients who have typical from atypical disease and potentially using it as a tool instead of MR or in conjunction with MR in terms of separating patients with high-risk disease. And at this point, I'm going to stop my talk, and I'm going to have you look at a couple of quiz questions. See if you are awake. So the first question is with regards to the utility of TKV, total kidney volume measurements. So total kidney volume is a marker of the kidney function or filtration. 2, it correlates directly with patient symptoms. 3, it predicts future loss of kidney function. Or 4, is different when measured by CT versus MRI. And let's see if you can cast your votes. Wow, incredible. So everybody was awake. So total kidney volume, it predicts the future loss of kidney function. Like I said, it's not a good predictor of current renal function. And let's look at the other options. So it's not a great predictor of current renal function. Patients with larger kidney volumes do tend to have more symptoms, but sometimes patients with larger volumes don't, it's not direct correlation. Sometimes we'd say patients with large kidney volumes may not have as much symptoms as somebody with not as large a kidney volume, but lots of hemorrhages within the cyst. And option 4 is also incorrect because CT and MR really should have identical total kidney volume measurements because they're depicting the anatomy very similarly, and it's just a matter of drawing the line around the outside of both of these using of the kidney using both of these modalities. Okay, and let's go to the second or last question. So it is important to differentiate typical from atypical patterns of polycystic kidney disease because atypical patterns have lower total kidney volume. Atypical patterns do not affect both kidneys. Atypical patterns result in no symptoms, or atypical patterns often have better prognosis. And maybe we can have you cast your vote now. Okay, very good. So I'm glad that people have selected other answers here as well. So let's go through them. So atypical patterns may or may not have lower total kidney volume. So sometimes we have patients with atypical patterns that have these gigantic cysts, and so their total kidney volume will be huge. But in fact, they have very nice, nicely maintained parenchyma elsewhere. So, total atypical patterns don't necessarily have lower total kidney volumes. Often they do, but not necessarily. Atypical patterns may or may not affect both kidneys. So So sometimes we can see atypical patterns that only affect one. So that's the asymmetrical, or rather the unilateral. But often it's asymmetrical disease where there is disease in both kidneys, but not symmetrical. So often they do affect both kidneys. And in terms of symptoms, yes, symptoms can be from the cysts, cysts themselves. So sometimes when the cysts are very large or there's hemorrhage within the cysts, patients can have cysts. So it doesn't matter if there is many cysts or few cysts, or if they're atypically distributed or not. So in general, patients with typical disease will have more cysts or more symptoms than those without, but that's not always the case. So, but generally, atypical patterns do tend to have better prognosis because there is some sparing of the kidney. So the patients may have renal failure later on in age or in life, or even no renal failure at all. So thank you so much for listening, and you did wonderful on the quizzes. So I appreciate that. I'll hand the podium back to Dr. Pei to introduce Dr. Klein.
Thank you very much.